So next, we'd like to welcome Jan Clarke with the presentation of BowALS, Understanding the Changing Bowel Habits in ALS. We were going to call this study Constipals, but it didn't have quite the same ring.
What was that?
Don't matter.
Yeah, I'm going to take this presentation in a slightly different direction now, about changing bowel habits in MND. And the importance of network meetings is where the origin of this conversation started for Rachel and I probably 6 years ago now. When we're just, you know how you are over coffee, just chatting about patients. And had this patient that was admitted to hospital, just in a crisis admission with an acute abdomen. And for those of you who wouldn't know, that would be a severe onset of pain in the abdomen for an unknown reason. And this was a young guy in his early 40s, and it was a terrible sort of sequence of events where this young man ended up having to have an emergency colostomy because he was so fecally impacted they couldn't resolve his pain at that point. And Rachel's going, but that happened to one of my patients. It was like, oh my God, is there something here that we should be looking at? Because fecal impaction and constipation and bowel problems really shouldn't happen in MND. It's not controlled by motor nerves. Why would that happen? And so then we had to backtrack and say, well, is there a problem? Do your bowel habits change in MND? So this study was a very small study that we designed to look at what the incidence might be in the changing bowel habits of people with MND. And one of the reasons for doing this is, of course, when our patients get admitted to hospital, they're usually out of their best environment, which is at home. Those environments aren't always good practice, especially on a surgical ward with no experience of MND, no experience of the complexity of communication. It's a very poor experience for our patients. So we decided to set this study up. We're very happy to say and thankful to the MND Association of England, Wales and Northern Ireland who helped fund this study for us. So this was a prospective study. I work in London in the UK and Rachel works in Oxford. And we took our 2 centres and it was a prospective study where we recruited patients coming into these MND clinics. And we wanted to record their usual bowel habits and their current bowel habits by using an online questionnaire. And alongside that, we looked at their ALS-FRS-R rating scale. We looked at their EQ5D from their anxiety and depression score. And we looked at something called a Bristol stool chart. And as I was drawing up these slides for here today, I realized that you might not know that Bristol is a place in the southwest of England. And a Bristol stool chart might not be an international thing. Now, don't get frightened. It's a diagram. It's not photographs. But it is a way for patients to record what their bowel motion was like, and so that we could have a look whether these patients were going to become constipated, or if they have PEGs, were they going to get more diarrhea from a change in their diet and things like that. And the questionnaire we asked them to complete, it's an online questionnaire, we asked them to complete it at 3 time points, so 6 months apart. This is a Bristol stool chart. It's not quite so frightening as you might have thought, but it helps us understand the type of stools that patients were passing. And so type 1 all the way to type 7 gives you an idea from very, very hard stools to just watery consistency. Not so scary. So we recruited 82 participants over the course of our study, and we received 125 completed responses in total. With MND studies, there's always a large attrition rate. 17 patients died during the course of our study, and 4 withdrew from participating. Of those, 46% of people reported a change in their bowel habit at some point during this follow-up period. And of them, 40% of patients reported being constipated as being the change that was not normal for them usually prior to being ill. So that's significant that the change in bowel habit was more common with people with an ALS-FRS score of 34 and under at first visit. And that's a significant change according to the p-value. So therefore, change in bowel habit and that change being constipation is highly associated with greater disability. It's also associated with a lower self-reported health score for those people, but not associated with an increase in depression. So from a small study, we concluded for this cohort of patients that there was an increase in risk of severe constipation in these patients as their disability worsened during the course of the study. Now, that's one thing. Then the other question is, what do we do about that? Because just knowing that isn't really that helpful. So we went on to look at a protocol for bowel management. And because we think this is completely preventable. These admissions are preventable. This quality of life would improve for people. This is manageable if we were proactive about it. So we have taken this protocol, and it's based on the end-of-life practice care pathway in Oxford in England, and we've taken the protocol for end-of-life, and we've just squeezed the time and a little bit. So what you're looking for, it's very hard to say what's a normal bowel action and how often should people open their bowels. The sort of acceptable way of looking at it is no more than 3 times a day and at least once every 3 days. So you understand if you're going to then start some medication to try and get some laxatives, try and get patients to go to the loo, that actually, if you're going to wait 3 days for a tablet and then before you move to the next strategy, you're suddenly starting to look at a severely impacted bowel building quite quickly. So this is our protocol, but I'd be interested to know from the nurses in the audience if you have a different way of doing this. But first off, we want to increase their fluids. It's a bit complex with MND, isn't it? Because if we ask you to drink 2 liters a day, which is really where we're going with this, then that means you have to go to the loo maybe a little bit more. And if the burden of getting up to go to the toilet either on you or your family, or if the burden is waiting for carers, external carers to come in to help you, that's a difficult thing to do. And I know that so many of my patients don't have a drink before they come to clinic, so they don't need the loo during the clinic time. I can imagine they're not going to take very kindly to trying to increase 2 liters of fluid a day. Increasing fiber seems a reasonable thing, but we know, as we've just heard from Good Look, that people, their diet changes. It's difficult to eat the diet that they need and what they want. And putting fiber as one of the laxatives that you can do through a peg tube risks getting that peg tube blocked. So it's not quite so straightforward. So there are 4 different types of laxatives that you can use from bulk forming, and they would be things like, I don't know if this is internationally recognized, something like fibrogel, which is a fibrous gel that you make up in a pint glass, and then you drink that, or you could put it through a peg tube, but the risk is that you block the peg tube with it, so you have to be very careful. There's osmotic laxatives that draw more water into the bowel to help move that stool down the bowel. The stimulants that stimulate the peristaltic action of the bowel, and the stool softness to try and make the stool easier to pass. So this is our first-line treatment, that if you're not already constipated, then you should be on Senna, just as a regular tablet to help increase your bowel mobility. If you are already constipated, we would recommend that you increase the rate of the dose of that Senna straight off. The end-of-life pathway would say then reevaluate after 48 hours. I don't think for our patients that 48 hours and with no result is quite good enough. So if there's no result on the next day, we'd then go to a second-line treatment, and we'd look at an osmotic laxatives for that. We have something called Laxido, which comes in sachets. You can have up to 8 sachets a day. We would start with 2 sachets for the first day up, and then increase them up to TDS if needed until we get a movement going, and then we would drop that back to 1 or 2 sachets a day. There's lactulose. Lactulose is a liquid, so it's quite good. It can go through a peg. It's quite sweet tasting. Some people don't like it, and some people are lactose intolerant. But it's one of the good things that you can do to give people that are becoming constipated. Lots of patients, though, complain it gives them colicky-like pain, so they don't like it so much. And then you can get something like Docusate, which is just going to make surface wetting laxative, so it brings more water into the bowel to make that stool easier to pass. Because remember, MND doesn't affect the bowel as such, but your ability to bear down as your abdominal muscles are lost does affect your ability to go to the loo. And third-line therapy would be look at a prokinetic medication that would stimulate the bowel into that peristalsis more frequently. So metoclopramide, which is an anti-sickness drug, is very good for increasing bowel mobility, but avoid if the patient feels very colicky, because you're going to increase the risk of discomfort. And then if your patients, their constipation is related to opiates, there's a very good drug called naloxegol that reverses the binding to those receptor sites to help prevent opioid-induced constipation. But it's quite expensive, and I can't find to get GPs to readily prescribe that. And then as if there's evidence of fecal impaction. This is what led all of our patients that Rachel and I were talking about into hospital, and this is where we really want to avoid this situation at all, that you can give aperients. So you would give bisocodal tablets, suppositories, but they need to be they actually need to touch the rectal wall to work. And if you're very loaded in your lower rectum, that's not so easy to do. And you probably need to have an enema to clear that first before then looking at maybe suppositories more regularly. And high impactation, so you can use an osmotic laxative that you can give rectally to try and bring more water into the bowel to bring down that high impaction. Many years ago in nursing, it used to be called when you gave enemas, it was like high, hot, and a hell of a lot to get things moving. But it's, well, you think about this, you think of the indignity of having to have aperients, the difficulty of your carer or your family member giving that to you, or the reliability of getting a nurse that can come into the home to do that on a regular basis to prevent your problems. It is far more complex, really, than really it seems to be, because of the help that you're going to need to do that. And then if you need carers to help you take you to the loo, in the UK, we have problems with providing care at the moment. You might get 2 carers that you need because you need to use a hoist, and if one carer turns up at 12 and the other one turns up at 12, and they're both due to leave at 12:30, you've got patients that sort of report to you that I get stage fright, I just don't have time to go. And so, it's a really complex situation. And then we have a new system that's come in the last few years in the UK, which is basically a colonic that can be given to a patient or their family member to manage on a regular basis. And it works really well at keeping the lower bowel clear. I don't know whether that's readily available everywhere, but it's now got something called NICE guidance. In the UK, that's a regulatory body that looks at the evidence against the cost of something and then said, this is a good treatment for you to have. So that's a whistle-top tour of bowel management in MND, but I'd be happy to take any questions that you may have. I'd also like to thank the participants and their families and the MND Association for their support with this study. Thank you.
That was fast.
You told me to keep it quick.
I told you to speak slowly. But fantastic. Thanks, Jan. Has anybody got any questions for Jan? Over here. Oh, marvellous.
Do probiotics or prebiotics help to better bowel movements?
I didn't quite hear that.
Do probiotics or prebiotics help to better bowel movements?
So I think the evidence on that is a little complex in that some probiotics don't actually, depending on how you take them, are destroyed by stomach acid when taken. So I don't know the answer to say there's any evidence to say that improves things from the study that we looked at.
There's a question at the... 2 questions. Question at the back. Phil.
Hi. Are you planning on doing any follow-up study now that you've got the protocol in place to see the impact of that or non-impact of that?
Okay, thank you. I think that's an interesting question, really, isn't it? So this is 2 cohorts of just 82 people with MND. So it's a very small when you think about that worldwide. But I would be happy to join up with other people if they wanted to look to take our study and to take our online surveys and use it in your own clinics to see if there's, is that the true incidence of change in bowel habits in MND? I suspect it is. It doesn't talk about cause, but if we could prove that there is an increased incidence, then we can put that into the body of evidence to say we should be asking about this at clinic all the time. And for those clinics that aren't specialists in MND, we get those doctors or those nurses to ask that question to make this a preventative problem for people with MND.
Thank you. Helen.
I just wondered if you've thought more about, or if there's any discussion around movement and actually helping the people. We used to have a tradition of tilt tabling quite a lot of people with MND to help them to stand to basically enable gravity. I wonder if there's the fact of less therapy that could be.
I think it's a lovely idea, but the idea of we struggle to get carers into the home to get patients to toilet on a regular basis, and we talk about routine being really important, and we fail to manage that on a large scale. I think if you've got inpatients, then I think a tilt table would work a little bit, but I think really it's about putting the basic care in, because with the right care and the right information, the right education, it's completely preventable.
I can't see any more questions for Jan. Oh, sorry, some virtual questions.
This is from Sandra from the ALS Association. Did you discuss how nerve damage, particularly vagal nerve damage, relating to increased stool disruption? Thoughts on that?
So, in theory, you shouldn't get vagal nerve damage, but if you get very constipated, you can splint your diaphragm, and that can affect your vagal nerve, because it can also affect your breathing. But no, this was really a study to look at, is there any evidence to say this is a problem in MND, because there is no evidence out there at the moment. Thank you.
I think that's all the questions. Any more questions? No. Jan, thank you.
My co-author, thank you.